Good afternoon, everyone. Welcome to another season, another year of Medical Grand Rounds. It's a pleasure to be back here. This year, our Medical Grand Rounds are going to be hybrid. So for those of you who are physically at the Glen, you are welcome to join us. For those of you who are not here, thanks for joining us online. Today, before we get started, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. So I would like to ask Dr. Ronna Livingston, who is the Chief of the Division of Respiratory Medicine, to introduce our speaker from that division, our speaker today. So Ron, the floor is yours.
Thank you very much. It's my pleasure to introduce Dr. Marta Kaminska. Of course, I know Marta since she was a resident, actually. And in fact, Marta did an excellent year of research in asthma with me and published a wonderful paper before deciding to pursue her goals in the sleep medicine and in ventilation. So my loss, but society's gain in general. Dr. Kaminska is an associate professor and a sleep-trained pulmonologist in the Respiratory Division at McGill. She's a scientist at the Research Institute of the MUHC and a member of the Respiratory Epidemiology and Clinical Research Unit, the RECRU. She's the medical director of the Quebec National Program for Home Ventilatory Assistance, and her research interests are long-term non-invasive ventilation, including in COPD and sleep-disordered breathing and neurodegenerative disorders and neuromuscular disorders and COPD. I look forward to hearing from Marta today about home ventilation.
Thank you so much for very kind introduction. This is day 2. Apologies for the technical difficulties of last spring. Hopefully this time all goes well. We will be talking about the so-called PNAVD, as most people refer to the program, which helps patients who are at home but who need some type of assisted ventilation. Conflicts of interest. So I work with Biron Soins du Sommeil and have some research funding. So the objectives today will be to understand the functioning of the home ventilation program, the PNAVD, to become familiar with some pitfalls in the care of those chronically ventilated patients, and review a little bit of emerging data on COPD, including from our own program. So the outline, we'll talk about the program first, the current situation in terms of numbers and so on, the chronically ventilated patient in the hospital, a little bit about the pandemic, some data, and COPD. So the program, so this is the front page of the website from the PNAVD, or the English NPHVA version of it. And you know, the title as well as this slide really are meant to drive the point that the program's principles include really patient empowerment and helping the patient who is at home to be able to function, to care for themselves, the patient or caregivers, the family. So it's a respiratory home care program, and the program provides machines and provides respiratory therapist care, but really the important thing is for the patients to be, for the patients really self-care to function so that they're able to stay at home. So we have pediatric and adult patients. The program provides primarily, the vast majority of patients in the program are on so-called BiPAP, or bi-level positive airway pressure ventilation. Patients may be on volumetric ventilation. They may have mouthpiece ventilation for support during the day. Some patients are on tracheostomy ventilation. Program also provides ancillary respiratory care, which is really key for the success of long-term home ventilation in terms of circulation management, so long volume recruitment techniques, as well as cough assistant techniques. And the program is also mandated to support patients with diaphragm pacemakers. So this is a busy slide, but really I just wanted to explain a little bit about the organization of the program. So the program started in 1993 with the aim of getting out of the ICU people who needed ventilatory support, but really otherwise did not need to be in an intensive care setting, such as patients with Duchenne muscular dystrophy, for example. So the program, therefore, is funded directly from the Ministry of Health, and in fact is 2 separate programs. So there is a program in Quebec City at the UCPQ, that looks after the eastern part of the province, and there is the program who is here housed at the MUHC. And so our program has different sort of modes of functioning. So first of all, the program RTs are directly responsible for pediatric patients and spinal cord injury patients across all the regions of Quebec. The RTs look after the patients directly in Montreal, but also some other regions such as Outaouais, Lanaudière, Abitibi-Témiscamingue, the James Bay, and Nunavik, often because of lack of respiratory therapists in those regions. In the Montérégie, so there is a partnership with the local CLSCs where the PNAVD RTs will provide the equipment, will get the patient initiated and started, and then transfer the care to those local respiratory therapists with support as needed. And then there are these so-called satellite centers that are somewhat independent with their own respiratory therapist personnel, but also their own medical directors and so on. So those are in Laval, Laurentians, and the Eastern Townships. The program, the MUHC program, is housed at the Allen Memorial Hospital, so the old RVH site. That's physically where people and the equipment are. So the program, provides a psychosocial, clinical, and environmental evaluation. Before patients can get a device, we have to make sure that everything at home is set up and adequate, appropriate for this to work. There are regular home follow-ups, as I mentioned, by the RTs, and this makes our program relatively unusual and unique, except for rare programs such as program in BC, but most places in North America, the devices come separately and the respiratory therapists sort of come separately. So here we have a really nice integrated program that allows us to optimize the care. And we do have a 24-hour-a-day on-call service in case, of some issues with the patient, whether technical or other health-related issues. The team, not only provides the equipment, they'll look at some, private insurance for funding if available. There's a delegated RT who will follow the patient long-term. And I highlighted this because really the high level of experience and training and super specialization, even of those respiratory therapists in the program, are pretty key, in fact, at ensuring success of long-term treatment in those patients. And in the image here, you see, I was talking about mouthpiece ventilation. So this is an example of the sort of pipe-like device where the patient can take SIP, so also called SIP ventilation. So the machine is on the back of the wheelchair and they can trigger breaths as needed without having a mask attached to their face. So there's support, as we mentioned, of the community respiratory therapists and as well as the family with, training and education to the family and to those community healthcare workers. And one of the mandates, in fact, is training and development of protocols. So protocols, for example, for cough assistance here, there are collective prescriptions for some of these techniques with specific, patient populations involved. And this is available on the website as well. Telehealth has been a big part of the PNAVD functioning much before the pandemic and Zoom and Teams that we now all use, but there were different platforms previously, so they were used for video conferencing and teaching and training, whether of entire teams or punctually individual respiratory therapists, but also with patients. As you can see in the top picture, on the right is the PNAVD RT, and on the left, at the remote side, the patient and caregiver and the local healthcare worker. And this is not a recent picture. So, given the, of course, breadth of the territory, this had been developed a while back. So who are the patients who, can benefit from these services? So there's specific admissibility criteria, both for adults and for pediatric patients that are somewhat different that you can find on the website as well. And these are developed based on this cadre de référence, so a guide, developed by a group of experts, but approved by the government, which is a bit aged now. It's from 2011. And unfortunately, these things don't change fast and not necessarily in line with the literature, but this is where things come from. So in general, for adult patients, I will focus on, to be considered for a BiPAP device or a ventilator, patient has to have symptoms of hypoventilation and physiological evidence of it, so an elevated PCO2 in a stable state. In some cases, nocturnal hypoventilation only can be considered a criterion. So, and then patient has to fall within a specific category generally, so neuromuscular patients, thoracic cage abnormalities, so kyphoscoliosis, spinal cord injuries, obesity, hypoventilation syndrome, various central apnea syndromes, but with hypoventilation. We're not talking about Cheyne-Stokes here or other types without hypoventilation. For COPD, there are specific criteria. We'll talk about that some more. Cystic fibrosis in patients who are being considered for a transplant as a bridging, and some idiopathic and other cases which can be reviewed, individually on a case-by-case basis for some exceptions and unusual presentations. So within those various diagnostic categories, when a patient goes home with their device, we have to consider risk management. We have to consider that the patient's home is not an ICU. And we'd like to be able to keep the patient at home and not, have any emergencies that will lead the patient back to the hospital or worse. So conceptually, we can think of different types of patients. Some of them are, fully independent, functional, working. We have patients working, desk jobs, but teacher jobs, construction jobs, who only require nocturnal NIV, such as patients with obesity, hypoventilation, for example, or some milder cases of neuromuscular weakness, etc. Then there might be patients who still only require nocturnal non-invasive ventilation, but who may be more dependent, who may have more impairment in both their lung function and their physical state. And then there might be the more dependent patients who are either fully dependent on non-invasive ventilation or physically very dependent, or on tracheostomy ventilation, which itself confers additional risks of the tracheostomy blocking or falling out, etc. And so, of course, this is, very broad categories, and within those are different types of patients, but this is something that we have to consider when the patient is going home with a ventilator. And conversely, we have different options in terms of devices that we can provide to the patients. So different types of BiPAP, bi-level devices with or without batteries included, with different types of alarms, different maximal pressure levels that allow for different ventilation modes, different types of circuits that can be used. In pediatrics, the minimal weight is an issue. And then some devices are approved as life support devices and others not. So how do we match the patient to the device? Some of the considerations are, well, what is the lung function, or what is something I would term the ventilatory reserve? And here I don't mean a measurement on the cardiopulmonary exercise test, but it's an empirical concept. If the ventilator were to stop, if the patient didn't have it, how long can they go on breathing spontaneously until they decompensate? And this, of course, can change in the setting of an acute illness or an infection. So it's very difficult to predict these things. Can the patient remove their own mask, and can they call for help if something were to happen? Can the patient wait for a new device to be delivered, in case of malfunction, the same day or the next day? Does the patient live close to the PNAVD or to wherever the device is? Or, do they live in a remote area with difficult access, for example, in the winter? Or if there's a power outage, can the patient wait, and how long for the power to be restored? So because of these different issues, different patient, types, as I suppose, and again, this is quite empirical, but we now have this sort of model of different levels of care, where the patients are divided into whether they use a ventilator at the nighttime only, and they get a simple bi-level device, except patients with neuromuscular diseases, because we're less sure in terms of where they're at. Perhaps if they develop an infection, we know that they're more prone to deteriorating, decompensating. Or patients who are unable to remove their mask or call for help. These patients will get a device with an integrated battery. And these also include, they're sort of a higher grade, I guess, higher level device, which also have more alarms that can alert, caregivers if something goes wrong. People who also require some ventilatory help during the day, so increasing ventilatory needs, will get 2 devices with an integrated battery. And then we also provide an ambu bag, basically a resuscitation balloon in case something were to happen. And then we have the most dependent patients, or those who use one of those mouthpiece ventilation setups. And that usually requires now one of those life support devices, so a more involved ventilator. Also, they get an external battery. So all of those, the ventilators do have internal batteries, but they don't last terribly long, depending on how the pressures and etc. Maybe 4 hours on average. So they'll get an external battery as well. And then we have the tracheostomy patients. So here everyone gets a life support device together with a resuscitation balloon. So how does a patient come into needing one of those or into the PNAVD? And there are different pathways, as it were. Some patients will be referred directly from having been admitted with an acute respiratory failure episode from an ICU. Some patients may be followed as an outpatient and be sent for a titration of BiPAP in the sleep laboratory and referred as an outpatient. Some patients may do what we call a daytime trial. So the PNAVD provides the service for some patients, especially neuromuscular patients, where a patient will come during the day and there will be, an adaptation period in terms of finding the right mask, putting the patient on the machine, increasing pressure levels, following vital signs, blood gases, and also the tidal volumes based on the machine, from the machine itself, which will provide information on the tidal volumes that the patient is receiving. And usually we aim for a certain level, 8 cc's, per kilogram, depending on the tolerance and so on. If the patient falls asleep, even better. And of course, there's always follow-up from this. And there's extensive training of the patient and the family, of course, again, depending on the specific needs. Patients will get a personalized binder with all the information they need, contact information, etc. Standard follow-up. So at most after a month, the RT will revisit the patient, and then every 6 months. So the OPIC, the respiratory therapy organization, mandates 2 visits a year for these patients, and that's what's done generally. We'll do an overnight oximetry yearly as well. We get downloads from the machines that we can follow that are sent to the following respirologist. And we can do overnight transcutaneous CO2 in very selected patients because the equipment is very finicky and you need to be sure that the patients can manage the equipment. So over the years, the program has done evaluation of a variety of technology, and some publications have resulted from this. So moving on to where we are currently, the program, as of May, had over 1,400 patients in the Montreal program and 887 in the satellite centers. So over 2,300 patients followed by the Montreal site and another 1,300 in the Quebec program. The rest of the data is only for the Montreal program. So you see about 11% of the patients are pediatric patients, and the rest are adult patients, divided about half into those above and below age 65 here. This is the number of patients sort of at the end of the year each year. The last year is not complete, but the program has grown really quite a bit over time, and over the last 10 years, it's more than doubled. These are the diagnoses. So as you can see, obesity hypoventilation syndrome is the most common diagnosis at this time. Neuromuscular patients remain the second highest, and then there are COPD patients, sort of divided, those who are obese versus those who aren't. This is the next largest if combined now. Central apnea syndromes, chest wall, a few spinal cord injury patients, a few cystic fibrosis, and other. And the other, as a proportion in pediatric patients, tend to be higher due to different various diagnoses. Respiratory therapists will perform a number of home visits every year. And you see that during the pandemic, there was a drop as there was, basically stoppage of any non-mandatory visits, and even many of the Q6 months follow-ups were delayed or deferred, but still there are a lot of visits that were not able to be avoided, and visits have come back almost to where they were. Some visits have been replaced by phone or video visits as the team and the patients become more familiar with Teams. But there are many visits that are unavoidable for patients, although equipment can be sent by courier and so on, but it's hard to fit someone's mask well by video. Okay, so I want to discuss a little bit some pitfalls with respect to when a patient comes to the hospital, and I'll start with a case, true story. So this was a 67-year-old male who presented to the emergency room at an outside hospital with fever, dyspnea, tachycardia. They were diagnosed with urinary and sepsis, maybe pneumonia. The past medical history was listed as follows: hypothyroidism, ALS, BPH, coronary disease with a stent 10 years prior, and utilization of BiPAP. Patient was in the emergency room, ended up being put on 2 liters of oxygen. The respiratory therapist did recommend that the BiPAP be brought and put on, which the wife did, but the machine didn't get installed. The patient was being transferred, so then when they were transferred, someone was supposed to install it there. That didn't happen. The nurse was evaluating the patient around midnight and everything seemed fine, breathing comfortably, vital signs stable. Midnight 30 or so, patient asks for their BiPAP. About an hour later, the nurse notices the BiPAP is still not on, so she calls the RT, and when the RT arrives, the patient is noted to be in cardiorespiratory arrest. The autopsy found no structural cause and concluded that asphyxia was the most probable hypothesis. And this made it, to the local news there near where the hospital was. Unfortunately, these types of situations happen recurrently in MUHC hospitals often not to this point. Often, the worst is averted, or if patient is, level C or end of life, like an ALS patient, maybe things don't get noted as much. Having said that, probably this was an avoidable death at this time. And so we don't want to be in the news for these reasons. Therefore, what are the, learning points from this case so that we can provide best care for life? First of all, when someone is on BiPAP, that likely means that they have chronic ventilatory insufficiency or chronic respiratory failure. And it's really important to recognize that BiPAP and CPAP are not the same thing. So, a patient who's on CPAP for sleep apnea, except for the, unusual case, if they miss their device for a day or two, generally they're going to be okay. For a BiPAP device, you better make sure, that the patient is okay if the patient is not going to have their device on, for any extended period of time. So a CPAP provides a continuous level of pressure, and the idea there is purely to open the upper airway, maybe give a little bit of positive pressure into the lungs, but it doesn't really provide any assistance with the ventilation, unlike a BiPAP machine, which provides positive pressure support during inspiration. So it does some of the work of breathing of the patient, and therefore, a patient may or may not be able to tolerate being without it, as we said. So these patients have limited ventilatory reserve and may decompensate even faster in the context of an infection or an acute illness. Patients with neuromuscular diseases are especially vulnerable. If they're looking, otherwise very stable and only use their machine at night, sometimes they can really need to use their machine even more during the day when they have an illness like that. And importantly, patients may not show obvious signs of respiratory distress. If their muscles are weak, they may not be tachyptic, they may not be taking large breaths. So beware of these patients. More learning points. So, as I mentioned, sometimes these patients, in fact, will need more use of a device when they're sick. And it's not infrequent for patients whom we follow when they have a respiratory infection to stay at home because they want to avoid often the hospital for a variety of reasons, but they will keep their machine on 24 hours a day for a few days until the infection resolves and then go back to their usual treatment. They manage themselves at home. So we have to consider that they may need more, not less, of their BiPAP. The supine position is particularly problematic, and in an emergency room, they're on a stretcher somewhere in a corner, not really attended to as well. that can really be quite dangerous, especially for patients who are, less mobile, can't call for help as well, and even worse so in an acute illness. The other important point is about applying oxygen to patients with, chronic respiratory failure. So we tend to think of this in patients with COPD sometimes, but it's also true for patients with neuromuscular disease. And if you apply oxygen to someone, you may actually cause them to go into hypercapnic respiratory failure. And the mechanisms for that include, it turns out the main mechanism is impairment of the lungs' ability to do VQ matching. So if there are areas that are not well ventilated, they're a little bit hypoxic, there will be vasoconstriction, and so you have less blood and less ventilation, and that's matched. Now, if you remove the hypoxia by adding supplemental oxygen, there will no longer be that hypoxic vasoconstriction, so there will not be VQ matching. So basically, you're diverting blood to poorly ventilated areas, and the CO2 exchange will be inefficient. There is also reduced ventilatory drive, as described in the graph here. So the hypercapnic ventilatory response really shifts in the context of hyperoxia and is reduced. There's a reduced ventilatory response. And there's the Haldane effect. So that happens at the level of the red cells and the hemoglobin, with more offloading of CO2 that contributes then to the PCO2. So if you don't remember the mechanisms, remember to be careful and to check the patient's CO2 if you're putting them on a machine. So if a patient is in the emergency room and you know that you're using a BiPAP, but they don't have their BiPAP with them, where can you find the information about that? So you can call the PNAVD at extension 32111, or there's always a respiratory therapist on call, in fact, that you should be able to get through locating. And if the patient is not followed in our system, they're in a satellite center, they can at least provide you the contact information, and not infrequently we'll also have the device information. If you look in OASIS, under the respiratory, documents, you might find these NPHVA documents. You may find download documents, and you might find some more information there than you care to know. But each device that the PNAVD has its own sheet. So this is one type of device. When a respiratory therapist goes to the patient's home, they'll fill one of these out. So in fact, often they'll get some vital signs. So here you'll know that the patient at the last visit of the RT had a saturation of 99% on room air. That can be useful to know what the patient's baseline, status is. And then you have the device parameters. So here you have the mode that they were on. And so here you have the pressures, IPAP and EPAP. And so this patient was on 26, I think, over 6. If you put this patient on, 12 over 4, then you're not really necessarily providing them the adequate support, right? So it's useful to know what the patient gets at home in normal circumstances. And then the download, so this particular device gives you the settings here as well. And there are different devices with different types of downloads. I'm really just showing this as an example. The RT may apply a sticker like this, which will tell you what kind of mask the patient had. And at this point, you've called your friendly neighborhood respirologist probably, and they can help you sort that. So this is also utilization of the device that you can get. And in this case, you can see the patient, every single day of this particular download was using their device 12, 13, 14 hours. So that can be useful information, and there's, more data. Okay, so a few words about PNAVD and the pandemic. Try to look, retrospectively at our data. We have fragile patients. And so here, this is monthly new admissions, new entries into the program. The line in the middle here, the dashed line, is the start of the pandemic, and each bar represents monthly new admissions. So you can see that starting from the pandemic, there was a reduction, at least for those first 2 years, compared with the 2 years prior. And in the different diagnostic categories. So some of this, initially may have been due to whether it's less patients needing it or patients not coming to medical attention and being delayed and accessing things, especially, for example, OHS. Often these patients, not always, but many of these patients will be referred from as an outpatient, and there were, none initially, so perhaps they weren't being, seen in the clinic. They weren't being studied in the lab, and so the information wasn't available to get them started. There seems to be a bit of a catch-up peak, but really still less throughout that period. So this here is the mortality during this period. So the timeline here is from March 2020 until 2 years later. And the mortality during that period is the top graph, the orange line. The gray dashed line in the background is the average for those months in the 2 years prior. So that's replicated twice here. So this is the average mortality and the mortality during the pandemic. The bottom graph, for reference, represents the excess mortality from Statistics Canada of all excess deaths in Quebec for that period of time, essentially. And so you can see that there's early on in the pandemic, there were certainly what seems like excess deaths in our patients also. After that, it's a little hard to be sure if there's anything beyond random variation. There's the Omicron wave here towards the end. So again, a little blip. So here is when the vaccination started. And there's a little blip here, a little blip there, but is that relevant? Hard to say, but nothing dramatic except, perhaps early on, which reflected really the general population. So comparing, in this other statistical modeling here, patients pre-pandemic, 2 years pre and during, using only patients admitted during that time to avoid a survivor bias, there was again no difference. When we tried to look at different diagnostic categories, the sample size became quite a bit smaller, and so there was nothing actually statistically significant, but there seemed to be trends. So the obesity hypoventilation patients seem to have a bit of a higher mortality during the pandemic, and that is also congruent with what we know from COVID, where people with obesity had higher risk of severe COVID and mortality from it. And interestingly, COPD patients had a trend for reduced mortality, perhaps, and whether that was due to confinement and reduced other viruses going around. And perhaps that's the explanation, but somewhat speculative and not statistically significant. All right, so a little bit about COPD. So I mentioned this cadre de référence, which, technically still defines, how the program works. Generally, based on previous data, on older data, there were no RCT trials at the time of this being published, showing any major benefit in COPD of long-term ventilation. However, the program did allow, the cadre de référence here allowed for certain specification cases. So if a person was being considered for a transplant, for example, as a bridging, so similar to cystic fibrosis, as we talked, patients who had recurrent hospitalizations with hypercapnic respiratory failure using BiPAP in hospital could be considered. And so we have been, admitting or patients in that category, or patients who could not be weaned, so often previously on tracheostomies, but then also on BiPAP, patients who could not be weaned because basically they decompensated pretty rapidly. So subsequent to that, some trials were published from Europe looking at COPD and BiPAP in COPD. So the first one on the left was a trial looking at patients who were stable, so had not been hospitalized, and who were hypercapnic. And there was a marked improvement in mortality in those patients. So it seemed too good to be true. A lot of people in the field weren't clear what to make of this large improvement and the specific methodology. The patients were being admitted very frequently to the hospital. It was felt to not necessarily be replicable in the North American setting, and it wasn't clear what to make of that study. Another study here, the Murphy trial. This one looked at patients who had just been hospitalized and were randomized to NIV or usual care about 2 weeks later. They also had to meet criteria for being on home oxygen. So quite severe COPD patients. And you could see, so this is rehospitalization, time to readmission. And the control group, 50% of the patients were readmitted in about a month. So quite severe a severe COPD group, and there was a significant, improvement. So delay in readmission, also reduced rate of rehospitalization. People didn't really die too much in this study, so that was not an outcome. So these studies, though, especially the second one, really started to change the thinking about this. One of the features and one of the sort of technical aspects of these particular studies was that they had used what was termed, loosely high intensity ventilation or high pressure ventilation. And what that implied is pretty high IPAP pressures. Now, none of these patients were obese or had sleep apnea, in these studies, but basically high levels of pressure. Initially, the high intensity ventilation required a high backup rate, but it turns out that it's the pressure that's important. So if you can call it high pressure ventilation and not use a target backup rate. The important thing is the high pressure, but in fact, really what the important thing is that you're aiming at reducing the PCO2. So you're not just providing a bit of support to the muscles. You really want to get that CO2 down, and that requires high pressures to drive that volume in fast. And the patients can have ideally longer expiratory time, prevent the hyperinflation, then reduce it in some cases, some data shows. So that was felt to be this high intensity or high pressure ventilation was felt to be the reason why these new trials were now successful. However, this trial was published. This was also post-hospitalization, randomized to BiPAP or not. And unfortunately, here in this study, there was no significant difference. But when looking in detail at the PCO2 over time, it turns out that in this particular group, the CO2 went down over the first 3 months, pretty much in parallel in the control and in the BiPAP group. And so it was felt that perhaps the patient selection wasn't right. It was too early. And in this study, patients were randomized within 48 hours of stopping the acute BiPAP, which was probably too soon. You need to give patients time to improve. These were probably not necessarily patients who were going to have chronic hypercapnia. They basically hadn't yet completely resolved their acute episode. Nevertheless, this, causes, negative results. So it always causes a bit of a commotion. The different trials, the new data led to, the writing of new guidelines. So the American Thoracic Society, the European Respiratory Society, and the CTS, the Canadian Thoracic Society, had produced new guidelines based on this new data. Having said that, the data is not very strong. So in general, the guidelines open the door for more widespread ventilation long-term in COPD patients, but with many caveats, and it's a weak recommendation. So, you need to make sure you're selecting your patient right, that they're agreeable to doing this, and that you have the right infrastructure, the right experienced staff, and that the logistics of this work. And also, we recommended the high intensity ventilation, even though there is no actual, long-term trial with outcomes data like rehospitalization or mortality comparing low versus high, but the trials that were positive that used this particular method of ventilation. What about in the PNAVD? So, before this, we still would take patients with COPD, as I had mentioned to you. And again, we were quite unique in our program compared with the rest of Canada. And even the Quebec program didn't tend to ventilate too many COPD patients. So we looked at the time period between 2014 and 2018, and we identified 267 patients with COPD in our program. So the main goal was to determine predictors of mortality, especially comparing obese and non-obese. But there's a few interesting things that come out of the data. So first of all, there were relatively few people who dropped out due to non-compliance, both in the obese and non-obese groups. So we had the majority were obese, as is expected in perhaps the North American population, as opposed to some of those European trials. But the non-obese people were also there. BMI is 22 and 43.5 on average. The PCO2 at the start of all this was around 60 in both groups, with an FEV1 that was considerably lower in the non-obese group. So there are obviously some differences in physiology, notwithstanding similar PCO2 levels between the two groups. So different settings on the machines, but again, in terms of adherence, 75% of the patients or more actually use their machine more than 5 hours a day. So, once they get it, they like it, they feel it helps, and therefore they use it. The non-obese patients, more than 7 hours a day. Mortality was lower. Survival was improved, is better in the obese group. And you could argue that the non-obese patients, were cachectic, etc. But if you divide into more narrow BMI subgroups, you could see that the more obese you are, the better you do. And this is the so-called obesity paradox that has been defined in COPD previously, that it turns out to apply also in ventilated patients and exists also in other disorders. Yeah, so the obese patients here, interestingly, did better. Mortality in the obese patients was predicted by chest wall disease, thoracic cancers, which are associated with obesity as well, and perhaps just longer survival, use of HOMO2, lower FEV1, and different specific ventilation parameters. Whereas in the non-obese patients, male sex for some reason, but also respiratory comorbidities outside of asthma, and by reviewing the charts, it turns out that these were bronchiectasis, pulmonary hypertension, and interstitial lung disease. And we know this phenotype of combined pulmonary fibrosis and emphysema definitely has a poor prognosis, with pulmonary hypertension often associated as well. So we were able to get RAMQ data as well, looking at healthcare utilization. And we compared pre to post, obviously not randomized, so it's worth what it's worth. But it turns out, so we're looking at patients who had at least one hospitalization prior to starting an IV. We can see that there is a reduction in all-cause and COPD-related hospitalizations, OER visits, ICU stays, and length of stay. The length of stay has to be taken with a grain of salt, because patients may have been waiting, in the hospital to get their machine. Having said that, it doesn't take 25 days to get a machine generally. So I think there is still some, relevance there in those numbers. And however, we also looked at non-serious exacerbations. So looking at discrete courses of antibiotics or prednisone, courses not associated with the hospitalization, and these were not different pre to post. So it looks like, being on an IV doesn't necessarily prevent a COPDer from getting their exacerbation, getting their infection, but it makes them more resilient for being able to manage it without having to be hospitalized. So, our program really does have the highest number of COPD patients across the province. We've developed quite a bit of an expertise, which has allowed us to publish this How I Do It paper with looking at the literature, but also some of our own experience. And I just wanted to finish by acknowledging the staff, the really excellent respiratory therapists, as I said, highly trained, specialized, and motivated. A group, only a couple of them here, but they really have the patient's best interest at heart. They are always keen to, teach, whether it's other respiratory therapists or residents, or, provide all the support that anyone might need for their patients, always looking to innovate. And it's just a great, interprofessional or multidisciplinary collaboration. So glad to be part of this team. And that is all I had today. Thank you very much.
Thank you so much. Thank you for this very comprehensive lecture on this very important topic, and really for advancing the field. You and your teammates here at the MUHC at the forefront of the literature in this area. We'll take any questions. Are there questions here on the floor? Mark?
I wonder if you could explain if there's any relationship between the McGill chronic vent program, or is that sort of, is it a backup, or are they directly related, unrelated?
So the Camille Lefebvre is a word at Lachine, which in fact originally was at the old chest and then sort of moved to the new Lachine Hospital and the chest was closed, which is really a long-term care sort of floor with ventilated patients. And Dr. Olivenstein can provide more background information, but they're essentially patients who are not in their own home. They need long-term care. So the PNAVD, in fact, officially and technically looks after patients in their own home as per Quebec definitions of various sorts, not CHSLDs, although they do have arrangements with other CHSLDs. But Camille Lefebvre, in fact, so they're ventilated patients, except they don't live in their own home. So the PNAVD doesn't directly get involved. The respiratory therapists of the hospital, look after the patients, and the respirologist there looks after them as well as needed. So they're separate, but of course they're similar patients. They're organizationally separate, but they do collaborate. The respiratory therapists talk, and we talk with Dr. Easy all the time as well.
Yeah. I could just add that most of the patients admitted at Camille Lefebvre come from other hospitals. So they're already sort of on a ventilator in a hospital, get on a waiting list. Occasionally, a patient will be admitted from home, someone who's been not doing very well, but most of those patients end up in a hospital and then get transferred, after several weeks or months, when there's an available spot to Camille Lefebvre. There's only about 25 ventilated beds available.
There aren't very many other places where patients on a ventilator can go if they need to be placed. So that's one of the few ones in Montreal.
Can you tell us if there's any literature in the heart failure population, because there's BiPAP is used in heart failure. Is there any information, any data on BiPAP type of in the night nocturnal?
So certainly in the acute setting, CPAP even can be quite helpful. BiPAP for acute, respiratory failure. But patients with CHF initially, in fact, and patients with central apnea, like Jane-Stokes ventilation, who have central apnea, they tend to hyperventilate actually rather than hypoventilate. So there are different types of devices that can be used in this context. So it's so-called servo ventilation. So there are BiPAP machines, but the algorithm is such that the Jane-Stokes breathing, you have the crescendo pattern. So these algorithms try to sort of mirror that, and in fact, may be able to correct the breathing pattern and normalize the breathing and resolve those central apneas. This is not a mandate of the PNAVD. So yes, there's literature on the servo ventilation and Jane-Stokes, type of ventilation. Of course, the first step is always to optimize medical management and reduce the Jane-Stokes as much as possible if the patient, the medical management obviously.
Yeah.
But sometimes patients can be on these devices. Having said that, the literature actually suggests that they do worse. That's a whole other topic itself. It's a can of worms. But so anyway, I think the jury's still out. There are different studies that are showing different things. Currently, because of this one large trial that showed actually worsened mortality in these patients with low ejection fraction, it's not recommended. But if you have a patient who has Jane-Stokes with a normal ejection fraction and let's say AFib, we see a lot of Jane-Stokes in that context. It can be used. Sometimes you can even use CPAP and it can correct it, and if not, we can try that. And so it's a different sort of population.
There's a question here from David Morris about the lack of efficacy of steroids you showed. Is this present in other studies?
Would you like to clarify that we showed in COPD, I guess?
Maybe I'll go on to the next question if he wants to. Jeff Whiteman is asking, do we have an organized flow chart to approach I forgot my BiPAP machine for patient with neuromuscular disease admitted at midnight to patient wards, or I would say the eMERGE-2. Do you have some sort of flow chart? What do you do if a patient comes in and you know they're supposed to be on a BiPAP machine?
So when they come to the emergency room, the emergency, has BiPAP devices available. And, as I mentioned, you can try to find what parameters they were on, and you can order a BiPAP, which DRTs will provide, not the same machine, et cetera, but you can apply a BiPAP. A patient like that should never be admitted on the floor without a BiPAP at midnight, or frankly at any point. They should, the next day someone can get their machine. I mean, again, I'm not sure on the medical floor how many patients on BiPAPs are actually admitted, and on CPAP if they're independent, yes, but on a medical ward, I think it's set up for disaster. So I would encourage you to avoid these types of admissions.
Just on rest.
Usually we admit them on the respiratory floor, which has BiPAP, the same sort of home BiPAP devices, and we can use those if the patient doesn't have to roam.
So, okay, thank you for that. Dr. Morris is saying, talking about the survival intervention statistics.
So the question was about steroids.
About steroids, yeah.
So that steroids, steroids are not a predictor of mortality, I guess, here. Perhaps it was related to this, that I'm not actually sure I understand the question, but here what we did is we looked at courses of steroids as a surrogate of a COPD exacerbation that did not require hospital admission, and these were not different before or after starting BiPAP. So patients still had, COPD exacerbations that might have required prednisone or antibiotics, but they were less likely to present to the emergency room or be hospitalized as a result. I'm not sure if that answers the question.
David, let me know if it doesn't answer your question. What about the cost of this? Is this cost prohibitive, or is it all covered by the RAMQ? What's the cost of this for patient annual cost?
So a device, can cost, there are different costs if you go yourself and buy it, right? Versus the cost that the program gets. But a BiPAP device, again, depending on what kind of device, can be the ones that are the most frequently used will be between $2,000 and $3,000. And then there are, the mask, the tubing, it's not the respiratory therapist, care visits, hours. And so, in fact, we had calculated some costs, and here I didn't put it, but it was very highly significant for cost saving. In fact, a day of hospitalization is probably, more than, or especially in the ICU, than one of those devices, which will last you several years. So the cost sounds prohibitive because it sounds like fancy machines, but many medications actually on a yearly basis will be much more expensive than a device. And, the home care, yes, there are some costs but it's much less than actually the cost of being hospitalized.
So overall, it's considered cost effective.
Yes, and there are studies in the US that have shown that, we haven't calculated it here sort of precisely, but from ballpark numbers, it was very, very significant. And there is literature on that from the US that in COPD at least, that there's major cost savings. Yeah.
Fantastic. Well, we're coming up on the hour. Any last comments, Ron? Is there a specific team, or is the RESP team that we call, or do you guys have a specific sub team?
So it depends what you're interested in. If you want you can call RESP, they can look into it. Certainly we have a sleep team sometimes, but certainly you can call the RESP team and they can then look into more details. Yeah.
Fantastic. Any last comments?
The only comment I'd like is that, the PCO2 that you're using for measurement to decide whether someone could be a candidate is by blood gas or by capillary blood gas. Here, of course, and at the general, certainly, they only use venous blood gases. Maybe you could comment that that's not an acceptable parameter to make a decision on, and why, and maybe a plea for using capillary blood gases elsewhere in the hospital other than at the Chest Institute where we've been doing it for 30 years and no one else has picked it up.
Correct. So, venous blood gases, there are many studies looking at this, are not very accurate or not, necessarily reliable indicator of the arterial PCO2, unlike capillary or what's so-called arterialized capillary CO2 at the tip of the finger or earlobe. Certainly a venous blood gas can be convenient to follow trends. However, it's the absolute value is not a reliable indicator of whether the level of CO2 is going to, be high enough for someone to meet criteria for hypoventilation and meeting criteria for PNAVD, or for COPD in particular, we require a CO2 of at least 52. And if you get a venous gas of 55, that means nothing. Like the arterial could be 45, so if you really need to get an arterial, and those capillary gases, indeed, they're very convenient, much less painful, can be done, very quickly. There are point of care machines that can be obtained, so perhaps certainly.
We're coming up, actually, it is 1 o'clock, so we'll have to close rounds. Thanks everyone for joining us today. Thank you, Dr. Kaminska, and again, congratulations on all the work you're doing in this field. Thank you for this excellent presentation. I wish everyone a great afternoon. We'll see you next week.
Thank you for the invitation.
Thank you.
Thank you.